Good day, and thank you for joining our webinar, QA with the Docs, How to Improve Hypertension Management. Our speakers today is Dr. Vicki James with Essential Medical Care and Ginger Irabetra with Dr. Kim's PC. Myself, Selena Williams, the Program Manager here at Hybrid Solutions, and Phoebe Nams, the Associate Project Director. Who is Hybridge? Again, my name is Selena Williams. I am the program manager here at Hybrid Solutions. We're located at Morehouse School of Medicine, National Center for Primary Care. The executive director is Carmen Hughes, and the executive medical director is Dr. Dominique Mack. Hybrid Solutions, our goal is to assist providers improve quality of care through EHR optimization, value-based clinical models, and connections to our health information exchange. Today's objectives is to overview and a background of the Hypertension Management Project, define the importance of addressing hypertension management to maximize patient care, discuss tools to utilize your electronic health record to identify patients with undiagnosed hypertension, and discuss provider challenges and lessons learned.
So today we have the privilege of interviewing someone who supported us in a very important project that is funded by the Department of Public Health. And we're glad that you could join us today. My name is Phoebe Nelms. I'm the Associate Program Manager here at Morehouse School of Medicine and the Health IT Division. And in that capacity, and under the leadership of Selena Williams, who's heading up this project, we've worked with the Department of Public Health in order to meet their objectives. And they've been funded by the Centers for Disease Control because hypertension is really a very important chronic condition to address and is a significant risk factor for heart disease and stroke, as well as preventable death and disability in Georgia. So that's why this project was very important to us, and we really appreciated the privilege of working with our speaker today, Ginger Irabetra. Hopefully I said it right. Yes. And she's been our rock star through this whole project, applying her extensive experience and background as a clinician and even as an instructor. And we're going to get her to tell us a little bit about herself, and then we'll get her viewpoint and experience with the project. So please tell us a little bit about yourself, how you ended up, where you ended up, and it's a very interesting journey, and I'm sure it'll inspire many.
Okay. Again, Ginger Irabetra. I'm a second career nurse. I spent many years, over 15 years as a teacher, a science teacher. And so I think that's what sort of helps kind of bring some of this, excitement that I have for the research part of the hypertensive study together. But I went back to school to become a nurse practitioner. I've been a nurse practitioner for 4 years now. I also get to marry those two together. I am a clinical instructor at Georgia State University. I started in that role as a part-time a few years ago, but full-time in this last year. I work in internal medicine. I see patients in a small private practice. It is myself, another nurse practitioner, and our physician that owns the practice. And it's that practice that we've been doing the work on this hypertension study project.
Wonderful. Thank you so much for that. So we had a hard time finding clinicians who would be willing to invest their time and energy into this. And we really wanted to bring value to the clinicians who participated. So what are your thoughts on your experience participating in this hypertension management project?
Well, it vastly expanded my understanding and my knowledge of these more community-based projects and these more community sort of global management. We've talked a lot, you and I, over the last several years about how we are trying to move from this pay for performance, or excuse me, the pay for visit to the pay for performance. And really we're in such a transition right now. We have providers, especially my physician who has been practicing for almost 25 years, and he's having to work to make that transition. And so just being a part of this project opened my eyes. As a nurse practitioner, I see patients in the office and, they're just on a schedule, and we see our patients, and we are learning about care management, and we're trying to incorporate that, but it's still something that I think we have a long way to go in really educating physicians, providers, PAs on what that concept is for actual care management that goes far beyond that 20 or 30 minutes that you have when you're sitting in the actual visit with the patient. The project helped me to figure out how to go about implementing a project of this nature, and what all it took to actually do that, and how many people it requires to implement a care project within an actual office setting. So yeah, it was just an incredible eye opener into not only what the project was, how you go about implementing a project, and also just the difficulty that it can take to actually implement these projects.
Thank you so much for sharing that. And that's why we really appreciated you, because your perseverance, professionalism, there wasn't any problem like, oh, we ran across quite a few problems, but you never said, okay, that's it, I'm done. Just kept pushing through. And so what we were funded to do is actually to find out how clinicians can use their electronic health record. It's a tool that sometimes they have a love-hate relationship with.
Very much so, yes.
But we wanted to highlight the positive impact, the ability to have this data and to organize it and analyze it can have on patient outcomes, especially around hypertension. Mm-hmm. So I know a lot of the work we did was, how do we generate the reports that show which patients are already diagnosed, which patients need to be diagnosed but haven't been. And so to that end, you helped us by asking your electronic health record vendor to implement an algorithm that was generated by the Centers for Disease Control. And that algorithm was designed to identify patients who maybe had a few elevated blood pressure readings, but were never officially diagnosed with hypertension. So would you describe how the challenges and the opportunities that were realized by the algorithm implementation part of the project?
Sure. So first, let me say I was surprised that there wasn't already something like that within the health record. I guess, I was just really surprised that it wasn't something that I could just run a report on to begin with. But there wasn't. And so it was interesting to figure out that wasn't always just available to you if you wanted that report. The problem came into when there wasn't that report, how to get that implemented. And I found it incredibly challenging to just working with our EHR, you submit a help desk ticket and you sort of wait several days to hear back. And as you recall, we were told that we needed to submit a formal request, which we did, and we waited months and we never got anything.
It went into the void.
Yeah, we went into the void. And it was just a matter of continuing to send emails. And I finally got a hold of the right person at this particular, EHR company. And it still was a challenge on trying to get the meeting together and really get them to understand that, we really want this done. Like, this is what we want done. And they were like, well, at first we were told it couldn't be done. Like, it just wasn't an option. But, we just thought, surely this can be done. That can. And so thank goodness, with, like you said, with lots of emails and lots of talking to lots of people, we were able to get it implemented. It was conceptually a very, very easy thing. But implementation was very difficult, and it took much longer than I thought. It just, send it to the developers, they'll code it out, and there will be, it'll be in the EHR, and that just simply wasn't the case. But once we talked to the right people, it was. So.
Yeah, that was wonderful when we finally got it implemented, but you also had to do some analysis of your own. I remember you crunching numbers and creating spreadsheets and comparing it with the results of the EHR generated report to ensure.
Right. Well, you had to check to make sure if the report was actually accurate. So, and that's what we found in the beginning when the first algorithms came through. I had to go in and pull each patient and find out, well, they either did or didn't, whatever. Their name is on this report, but yet there is no evidence of an elevated blood pressure. So we had to do some tweaking to figure out, if the report numbers actually were valid, because it's a completely useless report if the data that it's generating is not accurate. So it took quite a bit of work, and like you say, printing out papers and going in one by one and pulling these patients' charts.
But then the good news, once you worked out the kinks and the bugs and gave them feedback and they addressed your concerns, then you had a report that was actually valuable. So what value did you find in the report? And I don't want to forget this, they then made the report available to all their users.
Yes.
Yes.
It's actually in that system. So it's available as a report that anybody that uses that particular product can pull.
So what was the impact on your patient? What were you able to do with the report once it was generated?
So this plain and simple is we were able to catch those patients who've fallen through the cracks, which is nice because that's exactly what the algorithm is designed to do. It seems like, how can they fall through the cracks? But you have patients that go to specialists, they go to a cardiologist, they go to a nephrologist, they go to a dermatologist, and they may get an elevated blood pressure there. And of course, the specialist will say, well, mention it to your primary care or next time you go. And it just sort of gets kind of passed along. And elevated, but only mildly elevated blood pressures are very easy to sort of sweep along, especially if a patient has come in as a sick visit, or they're in pain, or there's, some kind of emotional trauma going on. And so that algorithm really gave us the opportunity to go back and say, well, I saw this patient, their blood pressure was elevated. Maybe I saw them for a sick visit, and I said, hey, please come back in a few weeks with a nursing visit and let's check this again. Or, I noticed that you haven't had a wellness visit in a year. Can you reschedule? And let's come back in when you're feeling well and let's check this blood pressure. But that's all well and good if the patient doesn't schedule, or even if they do, you don't know if they have called a week before and canceled that appointment. And so you're trudging along, seeing patient after patient, and never, that patient just goes away. But when you run that algorithm every 3 months and that patient's name pops up on that algorithm report, you can go, we don't have a follow-up blood pressure on this patient. And so it allows our MAs or other office staff to call these patients. And even if we can't make them come in, we can help them to understand that we are monitoring, we are looking at those sort of things, we are paying attention to it. And if they choose to, or maybe that prompts them to go check their blood pressure, maybe at a pharmacy or something. And it gets the patient, to refocus back on their health, even if it's not necessarily us that they come to get that blood pressure rechecked. So, like I said, the easy part of it is not letting these patients fall through the cracks. The other part is even other providers within our same practice. Like I said, we have 2 nurse practitioners and a physician. And if the blood pressure is elevated for me, and then they see the other provider later and it's elevated for them, they might not catch because they weren't the one that saw them 3-4 months ago. And so they might just not kind of catch the fact that there's a problem here. So that helps to bring that to light even within the same practice, because patients don't always see the same, physician, same provider, same mid-level whenever they're coming into the office.
That's excellent. So that's why this falls under the category of a quality improvement initiative, because it helps you improve the quality of care by catching those people who might have
Otherwise, just and we found several of those patients that were like, you know what, they've had good blood pressures, but yet now that we really dive in, and that's the part that makes it that care management, not just what are we doing in the 20 minutes that we see the patient, but are we managing their care over a period of time? And that gives us that opportunity to sit down. And it also is time saving, because you have MAs that can sit down with a list of 5 or 6 patients and can focus on that one task rather than having to do this sort of here and there. They can sit down and work at the report and make those phone calls.
That's fabulous. So what insights, I asked you that already, you were able to catch those patients. And you also implemented remote patient monitoring, and we just touched on that briefly about how some patients, when they were utilizing that technology, reporting their blood pressure automatically to the practice from home. How did that help you to also do care management?
Well, when the patient is compliant and takes the blood pressure, and you can log in and you can see this without the patient being in the office, it's easy to see how well that can help you to adjust their medications. If a patient's blood pressure is not under good control and we make a medication adjustment, it is often a month, maybe 2 or 3 before that patient returns back to the office. And too often you find out that medication may have helped, but it didn't help enough. With remote patient monitoring, you are able to see within a week's time, 2 weeks' time, enough time for the medicine to really kind of get in there and have a chance to work, but you don't have to wait 1, 2, 3 months to find out what the effect is. So you can make those changes on a much faster basis. Now, there's certainly compliance issues that come along with that. You can ask the patients to take these monitors home and use them, but you can't always get compliance. But for those patients who are compliant and who do use them, it really speeds up monitoring, and it also keeps you from over medicating patients as well. It's one thing to bring down a blood pressure, but the worst thing would be to bring them down, way too far. And, then you have a whole nother host of issues that can go along if a patient's blood pressure is too low. So I think the patients feel, again, better cared for if there's somebody looking out for them.
That's a great point. Patients feel better cared for, so more satisfied with their care, which is great for your practice's reputation. Tell a friend.
Exactly.
And also, there's a lot of emphasis on patient engagement these days. So I guess that also helps, the remote patient monitoring helps.
Yeah, I think feedback for patients to be involved in their care, it brings about questions. I said I'm an educator. So, to me, education and patient education is essential. And when a patient is involved in their own care, sometimes they just don't know what they don't know. They don't know what questions to ask. But when they notice, my blood pressure is running high today. Oh, you know what? I haven't taken my medicine in the last 3 days. They see an immediate feedback. And then all of a sudden, when they take their medicine for several days in a row and they're checking their blood pressure using the remote monitoring, they can get that quicker feedback for themselves, their own self-education as to how effective this medicine can be, whether they take it or don't take it.
Yes, not only medication, but probably, I went for a walk 3 days in a row. My blood pressure.
Absolutely. Or, that wonderful treat that they had with pizza or wings or whatever their treat is. They can also see how that sodium could potentially, cause some issues with their blood pressure.
Yeah, excellent. Well, we really, really appreciate all the hard work you've done to make this project successful. And outside of that, just from having worked with you over the last 3 years, at least,
Yes.
Getting to see your passion and commitment to the well-being of your patients is
Thank you.
inspirational.
Thank you.
It's just been an absolute pleasure to work with you and to see how much you care about your patients.
I have learned so much. So, I've gained a lot from working in this project.
Oh, that's what we love. We love win-win.
Yes.
And I just want to thank you, Ginger. I know I didn't work with you as closely as Phoebe did, but you were definitely a champion. And as Phoebe mentioned, we have had challenges getting providers to participate and be consistent. And you have went over and beyond, and you even got to experience attending the DP8 symposium with us. Is there anything you want to add to that? Any takeaways that you learned from attending the symposium with us?
Oh my goodness, that was wonderful. Again, I keep saying it broadened my knowledge. When we practice and we nurse such on an individual patient level, and then to see this whole other side of patient care that is the public health, realm that I don't necessarily know that much about, but I feel like now I do. I certainly feel better educated about it. All the people that are working tirelessly in the background, not necessarily in the office visit with the patient, but there's so many people working for patient care that the patients never even see.
Yes. Those people who are in the trenches trying to address the social determinants of health and those things that they say impact a person's health at least 80% of their well-being. Happens outside, 80,
outside 90%, of that,
outside of your office.
Absolutely.
So it's a community approach.
Yes.
And we're glad that you were able to be there and get that experience.
And that we got a chance to meet you in person.
Yes.
Yes. Especially
that was wonderful.
Due to COVID. All right. Well, we thank you again, and we're going to move on to our next expert, and we thank you again and have a wonderful day.
Great. Thank you.
Hello. My name is Selena Williams. I am the Outreach and Engagement Manager here at Hybrid Solutions. It has been the project lead on this hypertension project, which was funded by the Department of Public Health for the last 5 years. The goal of this project is for physicians to use their electronic health record to identify and manage patients with hypertension by enhancing and maximizing tools within their EHR system. Next, we have Dr. Vicki James, who I have had the pleasure of working with for the last year. Dr. James, can you give us a little bit of background about yourself?
Sure. So I am a Texan by birth. So that meant I went to the University of Texas Medical Branch down in Galveston, Texas, and did my training there. And then I wanted to go see what it was like in Pennsylvania and learn how to ski. So I went to Harrisburg, Pennsylvania, and did my residency in family medicine, and I learned how to ski. And then I had a National Health Corps obligation to repay back. So I went to Altheimer, Arkansas to do that for 2 years. And then a headhunter was looking for a family doctor for a small town in Georgia called Butts County. And they found me and I went down there, and that's what got me to Georgia. And so I've been in Georgia since then. And now I'm in College Park.
Well, thank you. Thank you so much for sharing. You never told me about the skiing.
Oh, man, I used to be a black diamond skier, and I could handle it. Way a long time ago. Won't do it again.
Awesome. So again, thank you for participating in this project. We've had challenges with providers being able to participate due to challenges in their office. And so can you share with us a little bit about the project, what you've learned, some insights, how it has helped you to improve the quality of care of your patients?
Absolutely. And first, I want to give heads up to my staff, because you're right. It did put a little bit of extra strain, and I just had folks who were committed to helping me whatever I wanted to do to make things happen. So you always got to thank your folks, because without them, nothing happens, right?
That's right. And I appreciate you being persistent and your staff.
Yep. And when we give out kudos, Miss Virginia in particular. So
that's right, Miss Virginia.
Yep, absolutely. Absolutely. So that was the staff. But then the other part to that is if you don't have patients who are willing to step out of their comfort zone and give you a little bit of extra time and extra energy, it still won't happen. So I need to just thank my patients for taking some extra calls and getting some extra blood pressures and then just getting hounded for more blood and just doing some stuff for us that made this happen. So for the whole essential medical care team, I'm just really grateful. Okay, so let's talk about what we learned by doing this. Okay, we found that the most important thing is it takes a team, as I just stated. I have in the past tried to do some things and just come in and tell my staff, I need you to do this, and then just sit back and wait for things to happen. But this time I gave them more responsibility because I was already overworked, just us trying to get out of the COVID thing. So with them taking more ownership, I think that helped us to be available to even work on doing this project, right? Okay, so what did we learn? You know, when you're primary care and you have chronic patients, then when they come in, you pull their record and you look at what's been going on, and then you put an individual plan together, right? Well, this opportunity was for us not only to look at them individually, but we also were trying to put them into a chronic disease community and to see, well, if I'm treating this person this way, why did it work on this patient? And you even had us to break it down in some age groups. And so when I broke it down into age groups, I was able to see that some folks, based upon their age, were more capable of doing something than other folks who are maybe older and didn't have some of the technical skills or
Right.
didn't have some of the support. So we had to look at managing them differently. So it opened up some cans of worms. Yeah, cans of worms about what you have to do when you really need to look at your community of a disease versus just the individual person. And then taking what you know about your individuals and what you've been trained to do with our protocols, you know, from American Heart Association, AAFP, all these folks are telling me what I need to get the best outcome. Using that information along with the patient and then with my community to see where can I cut and weave and make a tapestry of a practice that is outstanding in its management of hypertension. So that was a big picture. That was a learning process that we went through.
Thank you so much for sharing. And I know by coming on site and, seeing the different challenges with the staff and, trying to implement some of the tools that was in your system that were in the system but wasn't enabled, and having to reach out to your vendor and facing challenges there. But one thing about it, you stayed persistent, you were determined, you met the expectations of the project. And so let's kind of talk about that, how you overcame some of those challenges that you faced doing trying to participate and meet the expectations. Me coming out on site every 2 weeks saying, Dr. James, did you print this report? Are you using your clinical decision support rules to identify these patients? And, facing those different challenges, how did you overcome those? Because we're at the end of the project and obviously you've done well. You've implemented some other things as a result of this project. So I kind of want you to share some of those wins with us.
Okay, so the first big thing, and actually it was with all the work we were doing, and when we finally got to the point where we were the accountant and start counting the goods and the bads and the differences and just trying to put it in order so it could be understood by anybody who looked at the data, what we were doing. I'm really excited that I'm going to be like just a shining star, right? So I went out there to find out what I had to do to be greater than the national outcomes that we're getting. Found out that was about 25%. And so I'm like, oh man, no problem. So we started looking at our numbers and categorizing control versus non-control and just putting things together. And then one evening after, you like, Dr. James, I got to get these numbers now. So I'm sitting down doing the numbers, and lo and behold, the national is 25 and we're 28%. So that was a downer. So then we had to go back and look at, well, what is still going on with your patients that that they're still not progressing the way you want them to progress, the way they need to progress. So that's when we started doing some diving into, besides medications, what else is your community not responding to that they need to respond to be better? So that's where I started spending more time even asking patients about their nutrition. And even when I did that, I mean, visit after visit, I'm saying you need to get the processed food out of your diet, get the highly salted foods out of your diet, and giving them handouts on things to look at, and they agree, and then they come back in, and just in a jovial way, you ask them, well, what did you eat for breakfast this morning? And sure enough, you still got those issues. You ask them how they're sleeping, and just about maybe 70% of people are not sleeping through the night. So you ask about what they do for fun, what they do for physical activity, and you're still hitting a wall that that's a difficult thing to do. Sometimes because they don't feel good in the community they're in, sometimes because they have 2 to 2.5 jobs that they're having to do, and whatever few minutes they have left, they're going to sleep. Sometimes, well, especially towards the end, it was starting to get so hot, folks didn't want to go out, and I'm assuming also that the house was too hot to increase your body temperature in as well. So the whole process let me know that, and I already knew this, but it just gave me more data, that you just can't give a person a pill and expect things to get well. Right. That it is a comprehensive protocol and treatment and lifestyle. And that was one of the other things that the support groups at home, folks were very limited in having other people be empathetic and sympathetic in what was going on with their health. It's like we have a few dollars, and the pork is the cheapest that we can get to feed everybody. So you eat the pork or you don't eat anything. So it was eye-opening. It was quite eye-opening, and led us to take a look at maybe trying to do some other things to try to get our people in a better place.
It goes into the remote patient monitoring, one of the tools that you implemented too. Do you think that was probably some of the patient challenges that wasn't successful with using that device was because of the support or the technology? They just, didn't have the support at home to be successful with it. So that's why they didn't use it, or maybe the age group that you were distributing these devices for. Because I know you mentioned that was one of the challenges too with your patients that were using the remote patient monitoring, trying to monitor their blood pressure and stuff at home. A lot of them wasn't as active or engaged in it as they should have been.
Yes, and when you talk about technology, it on multiple levels, it did not provide the support that you just assume that it would. And the first level of support, of technical support that we really didn't get was our internet providers. We just sort of joke here that we can tell what time a day it is, how close it is to 5:30 by how fast the internet or how slow the internet becomes.
Right.
We have to start sharing the internet service with the residential community. So that slows down our time in being able to even try to get people online to take a look at their recordings and have those kind of technology assisted visits. So that was one area. And just like you said before, we have a lot of patients who still have the flip phone. And this is not the flip phone that costs $2,000. This is that can do anything. This is the flip phone that you make a phone call on, and you're pretty limited on being able to do anything else with it. That was a major issue for us. And then the third part of the technology, and we sort of hit on that too, was having an EHR that could be creatively independent when you asked it to help you design a specific protocol that would allow you to go deeper into your patient's disease and how you can take a look at what's recorded in the system to help you tease out and maybe find some solutions and maybe be able to follow that going forward. I know we asked the system, this was way back in, we did it twice, but the last time we did it in April, they never even answered my request on that one. So technology, depending on where you are, I'm assuming, because that's not where we are, can be beneficial, but in some instances, technology is another failed procedure to try to get to the outcome that you're looking for. And then the final thing with technology happens to be on me. My ability to use social media to meet the patients, meet some of the patients where they are, is very limited. I mean, I've had multiple people help me try to get into the Facebook, try to help me get to, I still haven't done the TikTok. I did a couple of TikToks, try to help me get into that part of technology that maybe on a one-to-one basis, I can have better interventions with patients. We're going to win that one. I'm still working on trying to figure out how to do the social media, because I'm assuming that if I can get that, and then if I can get the patients who really need that information, to get them to use email. That was the other thing, just trying to get patients to give you emails, and emails that were their emails and not the emails of their children that they don't see with any kind of regularity. So they basically can't see what you're sending them because it's going to the kid. Now, I'm helping the kid not to become hypertensive, but I'm not helping the mom better control hers. So technology was an eye-opening disappointment.
Hi, Dr. James. This is Phoebe Nelms. And
Hey.
yeah, I had the privilege of visiting your office once. It was so great to meet you.
Absolutely.
And one of the things that I was really impressed with was how you use your electronic health record to segment your population of patients, to, you know, divide them out by age groups and who has a diagnosis and what range. You didn't just say, yes, they have a diagnosis of hypertension or not. You really did a lot of analysis to see, okay, who has it between, you know, this range and that range and the other range. And I thought that was a tremendous use of, you know, your electronic health record to identify those patients and give the ones that really needed special attention your focus.
Yeah, and then the other thing that allowed was, and it was sort of surprising, that some patients would be under perfect control for 6 to 9 months, and then something would happen and they would fall out of that control and move into one of the non-control groups. So that's what I keep saying, that if you are not surrounded by a community that is always watching your back, you know, it's easy to fall. It's easy to fall. And that's probably the hardest thing, that you've spent all that time and energy, and to get to a good place, and something in your environment happens that pulls you out of that safe, good place and puts you back where you were before. That's devastating. And I see it with a certain level of depression when patients come in, after they've been doing well, and then, we have to give them the information that, no, you're not doing well anymore. What happened? And sometimes it's just that the rest of the community pulled them away from doing the right thing. So what you gonna say?
Yeah, that kind of goes into just the last question I have, and something I want you to kind of elaborate on what Phoebe was saying. I've noticed since I've been working with you, you've always been proactive or coming up with different measures, trying to get your patients to be more proactive and take responsibility for their care. I know when I remember the first day I spoke with you, you talked about how you had these exercise sessions and at your office where patients can come out and exercise. And as we wind down the project and get towards the end of the project, you're working on this algorithm. You created an algorithm. You're willing to give incentives to patients that are, successful in participating in the project. So I kind of wanted you to elaborate on that. Have you implemented the project? Have you chosen the patients? I think you're going to choose like 26 patients to participate in the algorithm, and you're going to get some incentives. Have you guys implemented or started that process? Where are you with that process? And what is to, find during that process of this algorithm?
Okay, so my team has been completely educated on how on protocols that they can use to engage patients. The last two were certified yesterday, so my team is completely in place. And then the plan is to start next week to start looking at putting the groups together. One of the things that I really found when I talk to patients about exercise, when I ask them, well, how much time are you spending? What kind of exercise are you getting? It was so vague, it led me to believe that they weren't even getting exercise, right? And something just sort of, just a light bulb went off in my brain that these folks are in such poor physical conditioning that the thought of getting out and exercising is just not possible. I even talked to a close friend who is about 5 feet, 300 plus pounds. And he shared with me what it was like the first day he decided to go outside and start exercising. And he walked 10 yards and just started huffing and puffing. So I'm thinking now that and I know that exercise is critical, but it may be that that's one of the hindrances that patients are having. So we're going to try to implement a program that works on improving their pulmonary function without actually going out and exercising first. Let's work on just getting the lungs healthy enough that you can walk down to the mailbox and you won't get short of breath. Maybe that will entice you to walk to your neighbor's mailbox and see if you can still go any further. So that's going to probably be my first implemented non-pharmaceutical process to see what that can do to improving blood pressure control.
That's impressive.
Let's hope it works. I'm sort of excited about that one, really. Mm-hmm. Yeah.
Well, Phoebe, did you have anything else you wanted to add, or any other questions for Dr. James?
I just want to thank you so much for being an advocate for your patients and for, using not only your medical knowledge, but even your creativity and your insight into what the challenges your patients face in living in community. So much emphasis is now being placed by Health and Human Services, CDC, on social determinants of health, because it impacts people's health so much. What happens when they're not in your office impacts their health so very much. So it's great that you're addressing those things as part of your your practice and that you emphasize patient education so much. It sounds like you're not just a clinician. It sounds like you have some research genes in there. And so it's really great to work with you. And thank you so very much for your contribution to our learning and to this project by the Department of Public Health in Georgia.
Well, it's my pleasure. So now what I would like to see happen is patients need to hear from more than just their provider. Everything that's important is on social media and television. And it's not in those areas when it is 2 o'clock in the morning when my patients are awake, but they're supposed to be asleep. It needs to be on at prime time. So there needs to be some prime time commercial what's it called?
Service.
Yeah,
PSAs.
yeah, PSAs things that that talk about what's a good blood pressure. I know no one will ever touch what's a bad food. You know, what food at any of the fast food restaurants you need to make a specialty meal that you eat once a month instead of a common part of your diet that you eat 3 times a week. But until it's until the community takes on ownership of making it more than just me in an 8x10 room telling patients that, I'm always going to be behind the 8 ball. So at some point, somehow, at 8 o'clock before the Monday Night Football comes on, some of the football players need to talk about their the challenge that their parents had, finally getting their blood pressure under control, and that they're advocate for doing this, that, and the other, so that the people who are spending the time watching them and enjoying them can watch and enjoy them for another 10 years before they get a stroke or a heart attack and takes them out.
Powerful.
Yes.
Yep, it's got to happen.
Well, it's been a pleasure working with you, Dr. James, and I'm always here.
I know
Project is ending. Anything you need me for, or Phoebe, if you have any questions, Highbridge is here to assist. Thank you so much for your time.
Thank you all as well.
Bye-bye.
All righty. Be well.
Thank you all. I hope that you enjoyed that informative interview with our clinicians that participated in the Hypertension Management Project. Just want to offer some continued education at no cost to you, well, cost of your practice, but at a discounted rate for Med-Approved. We have a discounted rate in the code here. If you're interested, you can reach out to Highbridge and I will provide that information to you. Also, some other upcoming learning opportunities through the Center for Leadership and Disability Training Opportunities. You will receive CEUs at no cost to you for participating. One of them is the Responsive Practice 1 is providing health care and screening to individuals with disabilities. And Responsive Practice 2 is accessible and adaptive communication. I think these trainings are approximately like 45 minutes to an hour. Again, it's a great opportunity to earn CEU credits. For clinicians, MAs, physicians. Our upcoming webinar will be next month, every Tuesday, every third Tuesday in each month. And the next upcoming webinar will be around MIPS QPP promoting interoperability. Thank you all again for joining. If you need any information, please contact myself, Selena Williams, or Phoebe Nelms.